So good evening, everyone. My name is Dr. Neeti Krishnan. I'm an orthopedic and sports physiotherapist. I'm practicing in Ahmedabad, Gujarat. So today's topic for webinar is biomechanical analysis. So we are going to learn the mechanics and pathomechanics of rotator cuff muscles. So to understand what are the pathomechanism under rotator cuff muscles, for that, it is very important to learn what are the mechanics, what are the kinetics and kinematics of the rotator cuff muscles. So today, for today's webinar, the content of today's webinar will be anatomical structures. We will be discussing biomechanics of rotator cuff muscles. Then what are the integrated muscle activity of shoulder complex? What are the physiology of abduction, and also the movement, and what are the muscles which act for the physiology of movement of shoulder joint. And last, we'll be discussing the pathomechanics of this particular muscles at shoulder complex. So let's begin. So let's see the basic anatomy. So the rotator cuff muscle, it is a group of muscles in shoulder, okay, which allows wide range of movement while maintaining the stability of glenohumeral joint. So if we say about rotator cuff muscle, it includes subscapularis, infraspinatus, teres minor, and supraspinatus muscle. So here, if we say about glenohumeral joint, so it's a ball and socket variety of synovial joint. It has a large spherical head within the small glenoid cavity. So such anatomical structure makes this joint highly mobile and very, very unstable. But there are few structures around shoulder joint which makes this joint also stable. So what are the stabilization structures? So we have contractile and non-contractile tissues which gives stability to the joint. When we talk about non-contractile tissue, that means that those are called as static stabilizers, and those are labrum, the capsule of joint, the ligaments around joint, etc. If we talk about contractile tissues of joint, it is called it as a dynamic stabilizers. So here we have the muscles, okay, which are the contractile tissues. So to be very specific, the rotator cuff muscles, the deltoid, and long head of biceps brachii. These are the muscles which gives amazing dynamic stability to the shoulder complex. So here, if we see the biomechanical behavior of a rotator cuff, it allows articular stability. It gives stability to the articulating structure. Now, if there is any tear of a rotator cuff, it altered the normal biomechanics of the joint, which leads to functional impairment. Now, to understand the biomechanical features of normal rotator cuff and what are the mechanical consequences of rotator cuff tear and their repair is very, very important, and why it is important. So today's webinar, it provides an overview of normal as well as a toned rotator cuff biomechanics, which will help us to make the best rehabilitation protocol for rotator cuff tear. So let's see what are the biomechanics of rotator cuff muscle. So it's a dynamic muscular tendinous unit that provides integral force in the elevation of the movement. When I'm saying elevation of movement, any kind of elevation of movement, it's not only abduction or flexion movement, elevation of flexion, forward flexion, abduction in scaption plane, etc. So the tendons of this rotator cuff muscles, it blend with the joint capsule and it forms like a collar, okay, which is surrounded by the glenohumeral joint. So if we say it is surrounded by posteriorly, anteriorly, and also superiorly, leaving the inferior part unprotected. So what are the primary roles? So the primary role is to stabilize the glenohumeral joint by compressing the head of humerus against glenoid cavity. So when there is a movement, if there is this shoulder joint, if there is a movement of abduction or flexion, so the primary role is to stabilize this joint by compressing the head of humerus against glenoid cavity. So if you see the action of these muscles, so let's talk about subscapularis muscle, the medial rotation of shoulder joint, supraspinatus, abduction of arm. The EMG studies have clearly, they are saying, EMG studies have shown that it is active throughout the abduction. There are few studies which was suggesting that the supraspinatus is very much active in 0 to 15 degrees of abduction only. But yes, it is necessary for initiation of movement. Supraspinatus muscle, the muscle contraction is important, but it is active throughout the abduction, just like any other abductor. So that we will discuss in detail. About infraspinatus muscle, it is a pure external rotator or lateral rotator of shoulder. With infraspinatus, we have teres minor muscle. It is again a lateral rotator of shoulder joint. So if you see each and every muscle, the image here, you can see, I need a pointer. Okay. So here, this muscle, you can see here, the name it says the supraspinatus. So it lies above the spine of scapula. Okay, it passes underneath the acromion process to attach the greater tubercle of humerus. So the portion is located in the supraspinatus fossa. It is not very superficial. It is deep to the trapezius muscle. Okay, and also deltoid at the lateral side. If we talk about infraspinatus and teres minor, so here again, see this image. Okay, so if you see the origin, the infraspinatus fossa of scapula, okay, and insertion is greater tubercle of humerus. Same like just down to this infraspinatus, we have teres minor. Origin as it is the axillary border of scapula and insertion at greater tubercle of humerus. So the anatomical structure it suggests, and that's how both are a strong lateral rotator of shoulder joint. Very important, that is subscapularis muscle. Subscapularis muscle, it gets its name from sub. Sub means under in Latin. So if we say it is underside of the scapula, lying just next to rib cage. So here you can see it is the anterior aspect. So actually it is the anterior aspect, right? The costal or surface of scapula. From the attachment, the anterior surface you can see here, the subscapularis muscle, it runs laterally, it crosses the anterior portion of shoulder joint and it attaches to the lesser tubercle of humerus. It is again a pure medial rotator of shoulder joint. Okay, so this was the basic attachment of rotator cuff muscles. Let's see what are the line of action. So all have line of action that significantly contribute to the dynamic stabilization. So here the line of action which you can see. Okay, for supraspinatus, it is going superiorly. Infraspinatus from insertion to origin, infraspinatus and teres minor, and subscapularis, the dotted line which you can observe here, it is oblique, but it is going anterior direction. So these are the line of action. Now, okay, so if we see the integrated muscle activity of shoulder complex, what are these activities? So in shoulder complex, each movement, each motion is associated with movement at multiple articulation. So it is always the relationship between the muscles, it constantly changes according to the movement. So if we talk about osseous or the bony stability of glenohumeral joint, the force generated by one muscle, it is called as a primary agonist muscle. It requires the activation of antagonist muscle so that the dislocating force does not result. Now, what is this? The antagonist muscle. So if we as per our concept, the antagonist muscle, it usually accomplish via eccentric contraction or lengthening of muscle. But other than this, there is also via neutralizing force. It also provides neutralizing force, which is equal in magnitude to the agonist muscle, but it is exactly in opposite direction. So one more time, I would like to repeat that the agonist muscle, it is a primary muscle, okay? But at the same time, it requires activation of antagonist muscle, which is in opposite direction. So here, if we talk about antagonist muscle, it is usually accomplished via eccentric contraction, whereby the muscle is lengthened while actively contracting, or it is via neutralizing force of equal magnitude but in opposite direction. So here the muscle which acts as a which actually gives a neutralizing force and just opposite to the agonist muscle, in it acts as an antagonist muscle. Those are called it as a force couple. So the relationship between two such muscles is also referred to as a force couple. So here at around the glenohumeral joint, there is a force couple in coronal plane between deltoid. So here first image you can see between the deltoid and the inferior portion of rotator cuff muscle, that is infraspinatus, teres minor and some part of subscapularis. Now here this is one group of force couple. We have another one at a glenohumeral joint, that is in transverse plane between the subscapularis anteriorly and infraspinatus, teres minor and posteriorly. So the basic action of this force couples are, it is active just like agonist muscle. The contraction, it is the similar like agonist muscle, but it is in opposite direction, so that it gives a neutralizing force to the joint and we can prevent the dislocation of the joint, or we can prevent the dislocating force at the joint. So it gives neutralization of joint. Now let's go ahead with detailed kinetics and physiology of movement. To understand the movement of shoulder, it is very important to understand the kinetics of deltoid. So let's see. First, we'll see the kinetics of deltoid. We'll see that how the muscle contraction occurs, and after that, we'll see the rotator cuff muscle. So here, to elevate the arm when you do abduction or forward flexion, the majority of force of contraction of deltoid is required, and it causes humerus or head of humerus to translate superiorly. So here in this image, you can see this the deltoid resultant. You can see here now it is giving a force. Here you can see Fx, which is a translatory force, and Fy, that is the rotatory component. So here when you do abduction, there is a muscle the deltoid will contract and it gives more of translatory force. So here that's how it tend to move to translate head of humerus in superior direction. It also produces shear force rather than compressive force. So that means deltoid cannot independently abduct the arm. So we need another force or set of forces. It must be introduced to work synergistically with deltoid so that the deltoid to work efficiently during abduction movement. So here we have very important and that is supraspinatus muscle. So here let's see how it is the force of contraction. Here this oblique line, that is a line of action of supraspinatus muscle. You can observe that Fx, that is the translatory component, the arrow, the force in translatory component is going upward, and here the horizontal, which you can see, rotatory component, which is more. So when you do abduction of shoulder, the initiation of movement, the supraspinatus muscle, okay, when supraspinatus muscle contracts, the translatory component is not more than rotatory component. So here, when you start doing abduction, the supraspinatus muscle will contract, the deltoid muscle also will contract. But here, the rotatory component of supraspinatus muscle is more. So that's how supraspinatus muscle can abduct the arm independently. Okay, and the deltoid here, you can see when you do abduction, the contraction of muscle which lead to translate the head of humerus superiorly. Now we have one more set of muscles. Those are called it as a force couples. We have other set of rotator cuff muscles. Those are infraspinatus, teres minor, and subscapularis. So these muscles individually or together have a similar line of pull. So here you can see they have similar line of pull, which is in downward direction, in oblique and inferiorly. So the rotatory component and translatory component you can see, which are almost similar. So it helps to balance the effect of superior translatory pull of deltoid, and that's how it acts as a force couple. So I would like to explain here properly. So this image everyone see, when you start doing abduction, the deltoid tend to translate the head of humerus superiorly. The supraspinatus muscle, it tend to rotate or it will initiate the abduction movement. At the same time, when the deltoid is translating the head of humerus superiorly, we have force couples. Those are infraspinatus, teres minor, and subscapularis. It gives a similar contraction, muscle contraction, but the magnitude is the same, but it is in the opposite direction. So when the deltoid is trying to translate the head of humerus superiorly, we have this force couples which are giving force in downward direction, and that's how it is helping in preventing the head of humerus into translating superiorly or dislocating in superiorly. So here let's see. So with the arm at the side, the directional force of deltoid is upward and outward with respect to humerus, while the force of oblique rotator cuff muscle is downward and inward. So as we discussed, EMG studies have shown that both supraspinatus and deltoid are active throughout the range of arm elevation. But here the role is very important. The supraspinatus muscle is very important in initiating the movement, but it is similar active as deltoid throughout the range of motion. So when you do abduction, the maximum role of supraspinatus muscle is at between 0 to 15 degrees because it is initiating the movement, but it is similar active as like deltoid muscle, but the angle of pull of supraspinatus is more constant at around 75 to 90 degrees of abduction. So when you elevate the arm, the compression force of deltoid is the same, okay, and it is very important. Now the remaining rotator cuff muscles, it will pull the head of humerus inferiorly at 45 degrees, and which will compress and depress the head of humerus, which again helps to improve stability. So here in previous slide, we already discussed the primary role of rotator cuff muscle is to provide stability to the shoulder joint during movement. So that's what I was trying to tell you, that during movement of elevation, even if it is abduction or forward flexion, the rotator cuff muscles, all four muscles are very active. One muscle, the supraspinatus muscle, is very active as an agonist muscle. At the same time, the other three rotator cuff muscles are very much active, and it acts as a force couple, which gives a same kind of force but in opposite direction. So let's see. So if we compare abduction with forward flexion, the same basic relationship is seen with rotator cuff acting as a stabilizer of glenohumeral joint, while deltoid provides the necessary torque. As I said earlier, the forward flexion results in activation of, so if we see with rotator cuff muscle, the muscle which are active, the agonist muscles are anterior and middle deltoid, with stability provided by supraspinatus, infraspinatus, and latissimus dorsi muscle. So the other kind of movement, that is the most basic motion of shoulder complex, it involves elevation of arm in scapular plane. It is also called as the scaption plane. So here the infraspinatus and subscapularis have significant role in scapular plane abduction movement. It generates the neutralizing force that are 2 to 3 times greater than the supraspinatus force. During this movement, the head of humerus remains constantly, almost completely centered within the glenoid cavity throughout the full arc of motion. So from 0 to 90 or 0 to 180 degrees, the glenoid, the head of humerus is constantly centered within the glenoid cavity. The force of contraction is much more than what we do in abduction. So the muscles, there are several muscles if we talk about in detail. So we have very initiation of movement, which includes the movement of deltoid, supraspinatus, serratus anterior. The second grouping of muscle, there are middle portion of trapezius, infraspinatus, long head of biceps. We have a third set and fourth set of muscles. So there are almost all the group of muscles that are active during this movement. And that's how this is a very important exercise which we teach during the rehabilitation of rotator cuff tear or after rotator cuff repair. So in summary, if we say the supraspinatus action is very, very important qualitatively in helping the articulating surface of glenohumeral joint together, and quantitatively in improving the endurance and power of abduction. Let's see what are the role of rotator cuff muscle as a rotator, so the external and internal rotation. So the primary external rotator of humerus is infraspinatus, okay, with significant contribution also made by posterior head of deltoid and teres minor. With any given amount of shoulder abduction, when you do any movement of abduction, the EMG studies reveals that the primary external rotator is infraspinatus. The subscapularis is similarly active but act as a neutralizing force, act as a force couple, act as an antagonist muscle. It will stabilize by preventing the anterior displacement of humeral head with external rotation. So here the subscapularis muscle act as a force couple during the external rotation of glenohumeral joint. Internal rotator. So internal rotation is accomplished by subscapularis, also the sternal head of pectoralis major, latissimus dorsi, and teres major muscle. Because the subscapularis has a horizontal line of pull, it attaches also the anterior to the humerus. It has become the prime mover of medial rotation of shoulder joint. So if you see, it is active, the muscle is active throughout in any phase of internal rotation, but the activity, the force of contraction, it reduces with extreme abduction with internal rotation. So this was the basic biomechanics of rotator cuff muscles. Now we will see what are the pathomechanics of these muscles. So the rotator cuff tears, it includes a variety of tear sizes, tear location, and very vague. So it is also associated with vague pathology. Now patients may present with spectrum of findings from no pain to severe shoulder pain, and also from normal function to severe dysfunction. So there are a few risk factors of rotator cuff tears which have demonstrated the importance of factors such as age, muscle quality, tear size on long-term patient outcomes. So here we see to understand the tear and how exactly it happens. Before that, let's see that what is the role of and what is the coracoacromial arch. So here you can see this image. The supraspinatus canal, it is bounded posteriorly by the spine of scapula and acromion, anteriorly by coracoid process, and superiorly by this coracoacromial ligament. And it forms a fibro-osseous tunnel or arch. It is called as a coracoacromial arch. So the star part you can see here, that is the coracoacromial arch. So why it is important? Let's see here. So this here you can see that if the muscle increases, so let me tell you before that. So when arm is at 0 degree movement, when arm is at the side, okay, where there is a 0 degree abduction or flexion, so the arch, the coracoacromial arch, the size is around 10 mm. When you move ahead, when you do abduction or flexion, when you do any overhead activity, it becomes 5 mm. So here, if the muscle increases in size, if there is any inflammation here at the tendon, or if there is any inflammation to this bursa, okay, so of course the movement, the tendons cannot glide through the canal without friction. So when you do abduction, patient will have pain, a jump, also called it as a jumping shoulder. When the rotator cuff is damaged because of degeneration or rupture of supraspinatus tendon, so there is no, so basically because of this damage, there is no, the humeral head, it will continuously impinge the coracoacromial arch, and that's how the impingement will occur. So direct contact between these two structures are very much responsible. It is associated with abduction in the syndrome of rotator cuff rupture. So here, patient's occupation is also one of the risk factor for both rotator cuff tears and failure after rotator cuff repairs. So if we see the occupation involving repetitive overhead lifting, which places a lot of stress on the rotator cuff muscle, which can ultimately lead to tearing because of repetitive movement. Also, while demographic factors such as age or occupation have been well cited as a risk factor associated with a prevalence of rotator cuff tear. So the recent attention has turned to genetic factors also. There are a lot of research is going on, and it need a lot of more research and data to look on this, that how the genetic factor also affect. Also, the size and morphology of acromion process are one of the anatomic risk factors associated with rotator cuff disease. So how? So there are like basic, if we see, there are 3 types of acromion process. Okay, first one is straight, the normal one, then curved, and the hooked one. So if person with hooked and curved acromion process, the morphology is, if it is such, then they are most likely to they're like the prevalence of rotator cuff injury is more on them. So if we see the common mechanism of injury, people who do repetitive lifting, as we just discussed, the repetitive lifting or overhead activities are risk of rotator cuff tears, like painters, carpenters, okay, others who do overhead work also have greater chance for tear. Second type of people, those are athletes, are especially vulnerable to overuse tear, particularly tennis players, baseball pitchers, etc. Tears that also happen suddenly, such as from fall, usually cause intense pain. There may be a snapping sensation and immediate weakness in your upper arm. So rotator cuff tear can happen. That is, first mechanism of injury is repetitive stress on the muscle, on the tendons. Second one is sudden fall. It ends up with rotator cuff tear. One more is very important, that is aging. With age, there is a tear, the damage at rotator cuff tear, and if patient falls immediately after that, or if there is a lot of weight on that shoulder, even with minimal mechanism of injury also, even if the mechanism of injury is not intense, patient are going for rotator cuff tear immediately. So here we are going to discuss the degenerative cuff tears. So what are the degenerative changes? So there are extrinsic theory and intrinsic theory. So if there is a downsloping acromion, what we discussed, the three types of morphology of acromion process. If it is curved and hooked type, then they are most likely to go for this tear. Second, any arthritic changes of our AC joint, acromioclavicular joint, which leads to acromion spurs, they are also most likely to go for degenerative changes. If we talk about intrinsic theory, then the degenerative microtrauma theory, the microtrauma generates at the tendons of rotator cuff, which leads to hypovascularity. And there is one terminology called Codman's zone, which is approximately 10 to 15 mm from tendon of rotator cuff, which is most likely to affect it, most likely zone where you get rotator cuff tear, mostly the degenerative cuff tear. Other than this, we have type of tear. So the risk is also according to the type of tear. There are posterior-superior and anterior-superior tear. So posterior-superior tears, it involves disruption of supraspinatus and infraspinatus tendon. And sometimes it also extends to the teres minor. If we talk about anterior-superior tear, it involves supraspinatus and subscapularis tendons. So this type of tear is very important when you rehabilitate your patient. You will be able to give a very good protocol after the repair procedure. There are also other type, there is other theory of rotator cuff tear, that is partial versus full thickness tear. So here you can see the partial one and full. So how to identify? So a partial tear goes only, there is a part of way into the tendon. It's usually described in terms of how deep the tear is in the tendon. It doesn't refer to the length, width, or any other dimension, but it is how deep it is. The full thickness tear is when the tear is in the tendon goes all the way through the tendon. So it is approximately, if we say, so according to research, the partial tear can be just 1 mm deep, okay, which is approximately 10% of the tendon. And if it is 3 to 5 mm deep or more than that, then it can be 50% or deeper. So that's how they identify the partial and full thickness tear. But you need MRI reports to identify and to diagnose a proper way of rotator cuff tear. With clinical examination, with clinical assessment and examination, we can give clinical diagnosis for further investigation. But for full thickness tear. For a proper diagnosis, you need MRI report. So what are the physical examination which we can do? First one is range of motion. Range of motion is most likely to be affected. Second one is muscle strength. So muscle strength testing can isolate the injury to the anterosuperior rotator cuff tear in case of internal rotation and abduction weakness, and with posterior rotator cuff tear, it will go into external rotation and abduction weakness. So there are also some patients, in some cases, the subacromial impingement also presents similarly to patients with true rotator cuff tear. So how to identify? So here, the physical examination manuals such as needs impingement sign, Hawkins Kennedy test are very, very useful techniques for determining whether the impingement is present or no with rotator cuff tear. So here I have made one slide of possible special test for each and every muscle to isolate the injury and isolate the tear. So we have supraspinatus, we have rent test, job test, drop arm sign. For infraspinatus, we have external rotation leg sign. For subscapularis, we have belly press test, list off test, bear hug test, teres minor, on blower sign, and external rotation leg sign. So these tests are very important. Unfortunately, we will not be able to cover the clinical perspective of this test, and we will not be able to give you demonstration of this test. Okay, so let's stick to the topic only. So once you are done with your physical examination and assessment, to rule out that which muscle is getting involved, and for differential diagnosis, and to go for a particular muscle testing, you can use any of this clinical test when you go for any assessment or examination. So I have added one slide on how to go ahead with our rehabilitation protocol. So here we can divide this, like I have divided in like a group 1, group 2, and group 3. So if it is a chronic full thickness tear because of degenerative changes over 60 years of age, so which is irreparable tears, initially with the help of orthopedic surgeon, we can go ahead with initial conservative treatment. After that, if it is required, we can go for surgical repair. There are other group of patients where there is acute tear, and having chronic full thickness tear, less than 60 years of age, sudden fall, can go for early surgical repair. After that, rehabilitation protocol. There are a few patients having tendinitis type of symptoms like tendinopathy, partial thickness tear, very small tear. We need to go for prolonged conservative treatment for such patients. So it is very important that each group of patients require a proper medical treatment followed by a proper physiotherapy management. And it is very important to give thorough and very important precise physiotherapy management, physiotherapy protocol for better prognosis of our patients. So I hope soon we will have a very good session with all the protocols of physiotherapy management, or protocols or rehabilitation protocol for rotator cuff tear. So thank you everyone for joining me for today's webinar. Soon I will come with another topic, another topic of discussion. So if anybody is having any suggestion, can please comment here. So it will help us to come up with another topic. Thank you so much.